Dear students, welcome back. In the previous sessions, we have seen the elbow joint structure as well as the function. In the structure, we have seen the articular surfaces and the ligaments and the capsule surrounding the joints and the mobility and stability of the elbow joints and the muscles which are crossing the elbow joint as well as the muscles acting on the elbow joint. Okay, now in this session we are going to see the radio-ulnar joints. So this radio-ulnar joints are the part of the elbow complex. So we are going to deal this radio-ulnar joints in this session. The radio-ulnar joints or articulations are of mainly two types. One is the proximal radio-ulnar joint or superior radio-ulnar joint, and next one is the distal radio-ulnar joint or inferior radio-ulnar joint. And normally in between these two, an interosseous membrane is present which is connecting the radius and ulna. So this one also called as middle radio-ulnar joints. Okay, now we are going to see one by one. In that, the first one is the proximal or superior radio-ulnar joint. In this, we are going to see the articulating surfaces of the proximal radio-ulnar joint. So the articulating surfaces of the proximal radio-ulnar joint includes the radial notch which is present on the ulna just below this trochlear notch, which is present on the lateral aspect of the ulna. And this radial notch is concave in shape and it is covered with articular cartilage, and a circular ligament called annular ligament is attached from the anterior edge of the radial notch to the posterior edge of the radial notch. So an annular ligament, a circular ligament called as annular ligament, which is attached to the anterior edge to the posterior edge of the notch. And this ligament, so this circular ligament which is attached here, this one is also lined internally by the cartilage. Okay, so that is articular cartilage. So this ligament is lined with articular cartilage and which is continuous with the cartilage lining of the radial notch. So this radial notch is concave in shape and this radial notch is covered by articular cartilage, and a circular annular ligament which is connecting from anterior edge of the radial notch to the posterior edge of the radial notch, and the inner lining of the annular ligament is also lined with the articular cartilage which is continuous with the articular cartilage of the radial notch. Okay, and this annular ligament encircles the rim of the radial head. So this cartilage which is going to encircle the head like this, encircle the rim of the head. So inside this, the radial head is going to articulate with the radial notch as well as the annular ligament. Okay, this forms the articulating surfaces of the proximal radio-ulnar joint. So the articulating surfaces of the proximal radio-ulnar joint are the radial notch which is located on the lateral side of the ulna just below the trochlear notch, and along with annular ligament. This annular ligament is also lined with articular cartilage, and this articular cartilage holds the which surrounds the rim of the head of the radius. So this head of the radius is going to articulate with the radial notch, so forming a joint variety called as pivot variety of joint. Here it is a diarthrodial pivot type of joint, and also it is a synovial. Diarthrodial means a synovial joint. So this is the articular surfaces of the proximal radio-ulnar joint. And mechanoreceptors are evenly distributed throughout this annular ligament, and the capitulum and the proximal surface of the head of the radius are actually the part of the elbow. Okay, so only the rim of the circumference of the head of the radius is going to articulate, and the upper part and the concave part of the superior part of the head of the radius is going to articulate with the capitulum, which forms the elbow joint. That is different from this one, but the capsule which is surrounding the elbow joint is also surrounding this proximal radio-ulnar joint. Okay, so these are all about the proximal radio-ulnar joint articulating surfaces. Now coming to the distal or inferior radio-ulnar joint, the articulating surfaces of the distal radio-ulnar joint include the ulnar notch of the radius. The ulnar notch of the radius, if you can see here, this is the radius. So this part you'll have the notch, ulnar notch of the radius, and the articular disc and the head of the ulna. So here you can see the articular disc. So here you can see very clearly this is the articular disc, and also the head of the ulna. So this is the head of the ulna. So the articulating surfaces of the distal radio-ulnar joint include the ulnar notch of the radius, the articular disc, and the head of the ulna. Okay, now the ulnar notch here, you can see the ulnar notch. Ulnar notch of the radius is located at the distal end of the radius along the interosseous border. The radius of the curvature of the concave ulnar notch, here you will have this concave ulnar notch. Okay, the radius of the curvature of the concave ulnar notch is larger than that of the ulnar head. So the notch is greater than the ulnar head. So the articular disc, so this is the articular disc. This articular disc is sometimes referred to as either the triangular fibrocartilage because of its triangular in shape, or a part of triangular fibrocartilage complex because of its extensive fibrous connections. Because this articular disc is going to be connected with number of structures, fibrous structures like palmar radio-ulnar ligament and dorsal radio-ulnar ligament, and it is also going to attach with the radial notch as well as the styloid process of the ulna. Okay. And now we are going to see in detail about the attachments of this articular disc here. So what are the articulating surfaces of the distal radio-ulnar joint? So the articulating surfaces of the distal radio-ulnar joint are the ulnar notch of the radius and the head of the ulnar and articular disc all together form the articulating surfaces for distal radio-ulnar joint. Okay, now so the disc has been described as resembling a shelf whose medial border is embedded in a wedge of vascular connective tissue containing fine ligamentous bands that join the disc to the ulnar and articular capsule. Okay, so it is a ligamentous band that join the disc to the ulnar. Here it is joined to the ulnar and the articular capsule. Next, the base. So this is a triangular one. It is having an apex and base. The apex is going to attach with the ulnar and its articular capsule, and the base of the articular disc is attached to the distal edge of the ulnar notch of the radius. And the apex of the articular disc, it is having two attachments. One attachment is to the fovea on the ulnar head. It is having some opening or some depression over below this ulnar head, so below the styloid process. So that one is going to attach, that is one attachment of the apex. The other is to the base of the ulnar styloid process. So one is the fovea on the ulnar head and another one is the base of the ulnar styloid process. Okay, so the medially the articular disc is continuous with the fibers of the ulnar collateral ligament. So these fibers are continuous with the ulnar collateral ligament which arises from the sides of the styloid process. The margins of the articular disc are thickened and are either formed by the integral parts of the palmar radio-ulnar ligament. So here you can see the palmar radio-ulnar ligament, and another one is the dorsal ulnar palmar ligaments. Okay, one is the palmar radio-ulnar ligament, another one is the dorsal radio-ulnar ligaments. So these are the attachments, and the ligaments are firmly attached to the radius. So these ligaments, this palmar radio-ulnar and the dorsal radio-ulnar ligaments, which are also attached to the radius. So the base is attached to the radius, ulnar notch of the radius, and the apex is attached to the fovea which is present on the ulnar head and also below the or base of the styloid process. And on either side the disc is attached with palmar radio-ulnar ligament and dorsal radio-ulnar ligament. And the thickness, if you see the thickness of the dorsal and palmar margins of the apex of the disc is approximately 3 to 6 millimeters, whereas the central area of the articular disc is thin and it is also transparent. This central area, so the central area of the articular disc is may be perforated, and this number of perforations are going to increase with age from 7% in the third decade to 53.1% in the sixth decade, and it is going to increase beyond this age. Okay, so this is about the attachments of the articular disc. And so some some of the investigators like Chidgey and colleagues studied in 12 cadavers found that the articular disc had a high collagen content and with sparsely, that means very less, but equally distributed elastin fibers, high collagen and low elastin fibers. And some of the authors found that the 80% of the central portion of the articular disc was avascular in comparison with the peripheral area, which was only 15 to 20% or avascular. So if you take this articular disc, the central thin portion is avascular, that means no blood supply here. On the when compared to the either sides, in either surroundings on either sides or surroundings of this articular disc, they are partly avascular, that means 15 to 20% of peripheral structures are avascular. Okay, but as the radio-ulnar ligaments are well vascularized, and some other investigators found that they will have some free nerve endings in the ulnar side of the articular disc. So on the ulnar side of the articular disc, they will have free nerve endings also present, particularly around the periphery. And the author suggested, by seeing all their findings, the disc may be the source of wrist pain. So this is very, very important. Why it is getting wrist pain, on which exact part which is causing pain, is because the articular disc, the ulnar side of the articular disc is found with free nerve endings, and because of the free nerve endings, it is having some nerve supply. So that is the area where the pain, source of pain is getting from the disc in the case of wrist pain. So you have to note this point here. Okay, now the articular disc has two articulating surfaces. One is the proximal, that is the superior, and the distal one. Here you can see the distal articulating surfaces here. So this is the inferior portion of the joint here. Here you can see the inferior portion of the joint and the superior portion of the articular disc. There are two articulating surface. One is the proximal. Here you can see the proximal surface, and below this you can see the distal articulating surfaces. So the proximal surface of the disc articulates with the ulnar head, and the distal radio-ulnar joint, whereas the proximal surface of the disc articulates with the head of the ulna as well as the distal radio-ulnar joint, whereas the distal surface articulates with the carpal bones as a part of radiocarpal joint. It articulates with the carpal bones as a part of radiocarpal joint, that is wrist joint. Both the proximal and distal surfaces of the articular disc are concave. Both the surfaces are concave in nature. So the superior surface of the articular disc is deepened. So the superior surface of the articular disc is deepened to accommodate the convexity of the ulnar head. To accommodate the convexity of the ulnar head. So the articular disc is deepened superiorly when compared to the inferior. Okay. Now the distal surface is adapted to accommodate the carpal bones. This one is going to accommodate with the carpal bones. The peripheral parts of both the ulnar and carpal disc surfaces are covered by synovium from their respective joint capsules. So, the peripheral parts of both the ulnar and carpal disc surfaces are covered by synovium from their respective joint capsules. Okay, now these are all about the attachments of the articular disc, and also some studies have found that how much collagen and elastin fibers are present in an articular disc, and its nerve supply as well as its blood supply, and it is having two surfaces, and these two surfaces, what are the structures are getting articulated with these two surfaces? In the proximal, what are the structures articulating with the articular disc? And the distal, what are the structures articulating with this articular disc? Okay, now the ulnar head is convex. Here, now coming to the ulnar head is convex. So we can see this is the ulnar head, which is convex and is covered with articular cartilage distally. So distally it is attached with articular cartilage, because that one is the structure which is articulating with the articular disc. So the distal part of the ulnar head is covered with articular cartilage, and this head has two articular surfaces. One is the pole and the seat. So this one is having, the ulnar head is having two articulating surfaces. One is the pole and the seat. Okay, this pole and seat articulate with the articular disc and the ulnar notch of the radius respectively. So the pole is articulating with the articular disc, whereas the seat part, so here you can see the seat part here, the seat part is going to articulate with the radius, ulnar notch of the radius. These are the two parts of the ulnar head which are going to articulate with each other. And the convex pole, here you can see the convex pole is U-shaped and faces the disc. The convex seat faces the ulnar notch of the radius. So that is the thing. So the seat is facing towards the ulnar notch, whereas the pole is facing towards the disc. So these are all about the inferior radio-ulnar joint articulating surfaces. Now coming to the articulations, overall articulations. So now we have seen individual articulating surfaces of each bone, isn't it? Proximally, what are the articulating surfaces, and distally, what are the articulating surfaces? Proximally, it consists of the radial notch of the ulna and the annular ligament, as well as the rim of the head of the radius. Okay, all these are going to articulate to form. These are all the articulating surfaces. Now, these structures are going to articulate with each other to form a joint. Okay. Now, and the same way the distal one also, the ulnar notch of the radius and the head of the ulnar head of the ulna, and along with its articular disc articulates to form distal radio-ulnar joint here. And the middle radio-ulnar joint are nothing but the interosseous membrane. Okay. Now, the proximal and distal radio-ulnar joints are mechanically linked. So, the proximal and distal radio-ulnar joints are mechanically linked each other. Therefore, motion at one joint causes motion at another joint. The distal radio-ulnar joint is also considered to be functionally linked to the wrist joint here. Here it is going to again articulate with the carpal bone. So the distal radio-ulnar joint also considered to be functionally linked to the wrist, in that compressive loads are transmitted through the distal radio-ulnar joint from the hand to the radius and ulna. So whatever the compression force which are created in the hand, which is carried through the wrist joint and then to the distal radio-ulnar joints. So the pronation of the forearm occurs. So pronation of the forearm occurs as a result of this radius crossing over the ulna, at the superior radio-ulnar joint. So at the superior radio-ulnar joint, this one is crossing the ulna here, and during pronation and supination, the rim of the head of the radius spins within the osteoligamentous enclosure, which is formed by the annular ligament, radial notch and the annular ligament. So in between this annular ligament and the radial notch, the head of the radius is going to spin inside. Okay. Now, another thing is, at the same time, the surface of the head, here the surface of the head is going to spin on the capitulum of the humerus. So these are the things happening at the proximal radio-ulnar joints during pronation. Now at the distal radio-ulnar joint, the concave surface of the ulnar notch, is going to slides. So ulnar notch of the radius is going to slide around the ulnar head, which is going to slide around the ulnar head, and the disc follows the radius by twisting at its apex. So here what is happening? The radius is crossing over the ulna. Along with this, the distal one, the ulnar notch of the radius, also sliding on the head of the ulna. So both will occur simultaneously there. Okay. Now the joint surface contact is optimal only with the forearm in a neutral position between supination and pronation. So the joint surface contact is optimal only when the forearm in a neutral position, that is mid-prone position. In maximal pronation and supination, the articulating surfaces have only minimal contact. Maximal pronation as well as in supination, the articulating surface will have only minimal contact. In full supination, the seat of the ulnar head rests on the palmar aspect of the ulnar notch, whereas in full pronation, it rests against the dorsal lip of the ulnar notch. So the joint articulating surfaces are in contact maximum during when this radio-ulnar bones are in neutral position, that is mid-prone position. In maximal pronation and supination, the articulating surfaces have only minimal contact. In full supination, here you can see the seat of the ulnar head. The seat of the ulnar head rests on the palmar aspect of the ulnar notch. So this is the palmar aspect of the ulnar notch. During pronation, what will happen? It rests against the dorsal lip of the ulnar notch. So this will rest against the dorsal lip of the ulnar notch. So these are the contacts of the articulating surfaces during motions, and also the articulations of proximal radio-ulnar joint as well as the distal radio-ulnar joints. So these are all the articulating surfaces of proximal radio-ulnar joint and radio-ulnar joint, and its contacts during motions. The articulating surfaces having how much contact present during motions in pronation and supination and in mid-prone position. In which position it is having maximum contact and in which position it is having minimum contact. Okay, so now we are going to see the ligaments around the radio-ulnar joints. Now in this ligaments, the interosseous membrane provides stabilization at both the proximal and distal radio-ulnar joints. So though it is considered as middle radio-ulnar joint, and this membrane will have the major function is to provide stabilization at both the proximal and distal radio-ulnar joints. If you see the proximal radio-ulnar joint, it is having 3 ligaments. One is the annular ligament. So you can see here the annular ligament, and one is the quadrate ligament, and next one is the oblique cord. So these are the 3 ligaments which give support to the proximal radio-ulnar joint. The first one is the annular ligament, which is very strong ligament, and it is a strong band that forms 4/5 of the ring. So you can see this ring is forming 4/5 of the ring that encircles the radial head. The inner surface of the ligament is covered with cartilage and serves as a joint surface. The proximal border of this annular ligament blends with the joint capsule of the elbow, and the lateral aspect is reinforced by, and this lateral aspect of this joint is reinforced by the fibers which form the lateral collateral ligament. So again we will see the annular ligament, which is a strong band that forms 4/5 of the ring that encircles the radial head. The inner surface of the ligament is covered with cartilage and serves as a joint surface. The proximal border of the annular ligament. So here you can see this one is the proximal border of the annular ligament, which is going to blend with the joint capsule of the elbow joint. So both the elbow joint as well as the proximal radio-ulnar joint having the same capsule here. So this capsule is going to blend with the proximal border of the annular ligament. So here in this joint they have pulled in this, they have pulled the radius down to show the annular ligament as well as the notch, but the joint is not present like this, it is present somewhat up. So you can see the joint here. Okay, next one is the and the lateral surface of this annular ligament is going to blend with the fibers from the lateral collateral ligament, okay, of the elbow joint. Now coming to the quadrate ligament, here you can see, so both the views of radio-ulnar joint, this is the anterior view and the posterior view, and you can see this is the quadrate ligament. The quadrate ligament extends from the inferior edge of the ulnar's radial notch. So the quadrate ligament extends from the inferior edge of the ulnar's radial notch to insert in the neck of the radius. To insert in the neck of the radius. The quadrate ligament extends from the inferior edge of the ulnar's radial notch. So this is extending from the inferior edge of the ulnar's radial notch, which is going to insert to the neck of the radius. This quadrate ligament reinforces the inferior aspect of the joint capsule and helps maintain the radial head in opposition to the radial notch. So this quadrate ligament reinforces the inferior aspect of the joint capsule. So, and also it helps in the opposition of the radial head to the radial notch. That means both the joint surfaces should be in contact and facing oppositely each other. Okay. Next, the quadrate ligament also limits the spin of the radial head in supination and pronation. So these are the functions of the quadrate ligament. So the quadrate ligament attachment, it is extending from the inferior edge of the ulnar's radial notch. One is the ulnar's radial notch to insert in the neck of the radius. The quadrate ligament reinforces the inferior aspect of the joint capsule. It is going to reinforce the inferior aspect of the joint capsule and helps maintain the radial head in opposition to the radial notch. The quadrate ligament also limits the spin of the radial head. So this ligament also limits the spin of the radial head in supination and pronation. Now coming to the oblique cord. So here you can see this is the oblique cord. So this one is the oblique cord here. This oblique cord is a flat fascial band on the ventral forearm. So keep it in mind, it is present. It is a flat fascial band. It is a flat fascial band on the ventral forearm. The oblique cord is a flat fascial band. Here you can see the flat fascial band which is present on the ventral forearm. So you just note this point. It is present on the ventral forearm that extends from an attachment just inferior to the radial notch. Here this inferior to radial notch, and it is going to insert just below the bicipital tuberosity on the radius or radial tuberosity. So this oblique cord is a flat fascial band which is present on the ventral forearm that extends from an attachment just inferior to the radial notch, which is present on the ulna, and it is getting inserted below the bicipital tuberosity or a radial tuberosity on the radius. Okay, next, how the fibers are. The fibers of the oblique cord are at right angles to the fibers of the interosseous membrane. If you observe the fibers of this oblique cord and the fibers of this interosseous membrane, if you see this two fibers, they form an right angles. The fibers of interosseous membrane and the fibers of oblique cord are arranged in right angles to each other. Next, the functional significance of this oblique cord is not that much clear, but it assists in preventing the separation of radius from ulna. Okay, so that is the function we can consider here. And coming to the other ligaments, that is dorsal and palmar radio-ulnar ligaments. Before going to this dorsal and palmar radio-ulnar ligaments, again we will see what are the ligaments we have seen which are attached to the proximal radio-ulnar joint. One is the annular ligament, which is the strong ligament, and then the quadrate ligament and annular oblique cord. So these are the major three ligaments which are related to the proximal radio-ulnar joint. Now, this dorsal and palmar radio-ulnar ligaments, and as well as this interosseous membrane, reinforce. So this interosseous membrane as well as the dorsal and palmar, this side we can get palmar radio-ulnar ligament, and the posterior side we can see the dorsal radio-ulnar ligaments. So these two ligament along with interosseous membrane reinforce. That means it gives some strength to the distal radio-ulnar joint. Okay, and this dorsal and palmar ligaments are formed by longitudinally oriented collagen fiber bundles originating from the dorsal and palmar aspects of the ulnar notch. Dorsal and palmar aspects of the ulnar notch of the radius. The two ligaments extend along the margins of the articular disc. At the center you can find this articular disc. So this triangular portion is the articular disc, and the surroundings are formed by this dorsal and palmar radio-ulnar ligaments. Okay. So the two ligaments extends along the margins of the articular disc, and they are going to insert on the ulnar fovea and base of the styloid process. So these two are coming to insert. I have mentioned that it is having two attachments on the apex side. One is the fovea of the ulna and the base of the ulnar styloid process. Okay. Next, the palmar radio-ulnar ligament is at least 2 millimeters longer than the dorsal radio-ulnar ligament. So this palmar radio-ulnar ligament is 2 millimeters longer than the dorsal palmar radio-ulnar ligament. And some of the investigators like Lynchid, the dorsal radio-ulnar ligament averages about 18 millimeters in length, whereas the palmar radio-ulnar ligament weighs lengths about 18 millimeters in length. So the dorsal radio-ulnar ligament is 18 millimeters in length, whereas the palmar radio-ulnar ligament is averages about 22 millimeters. Okay, so this is 18 millimeters and palmar is 22 millimeters in length. The interosseous membrane, which is located between the radius and ulna, is a complex structure, and it is divided into three components. So this interosseous membrane is divided into three bands. One is the central band, another one is the membranous portion, and the dorsal oblique cord. So here you have to consider here, on the ventral side also we are having ventral oblique cord. That one is different from the dorsal oblique cord. Okay, so now again we will see the interosseous membrane, which is located between the radius and ulna, is a complex structure consisting of the following three components, that is the central band, membranous portion, and the dorsal oblique cord. Okay, here you can see this dorsal oblique cord on the posterior view. This is the dorsal oblique cord. The central band is described as more strong than the remaining two components, and this central band is strong and also thick ligamentous or tendinous structures consisting of bundles of fibers that run obliquely from radius to ulna. And the central band, so you can see the fibers are running from radius to ulna. You can see these are the fibers running inside the central band of the interosseous membrane. Okay, the central band is having high collagen content arranged in fibrillar structures which are surrounded by elastin. So the collagen which are arranged here is in the form of fibrillar structure, fibrils. Okay, so in the muscles we have seen the arrangement. Okay, so and which one is surrounded by the elastin. Okay, this is the composition of the central band of the interosseous membrane. The collagen content is more abundant in proximal bundles than in the distal bundles. So the collagen content, so if you make this, it is proximal and distal. So towards the proximal, the collagen content is more than the distal portion. Okay, next, when the tensile strength of the central band was compared with the of the patellar tendon, the investigators found that the ultimate tensile strength of the central band was 84% of the strength of the patellar tendon. So the tensile strength, once they checked with that of the compared with that of the patellar tendon, they have found that it is having an ultimate tensile strength which was 84% of the strength of the patellar tendon. Normally this patellar tendon, definitely it is very much strong because of its position of the tendon and which helps in the extension of the knee joint and also helps in the weight bearing. So that means the tendon definitely will have more collagen and it is having more tensile strength. So when they compared with this patellar tendon and with that of this central band, 84% of strength of the patellar tendon which was going to exhibited by this tendon, that much of strength is exhibited by this central band. Okay, next, this central band is having, finally what we can explain with this central band is, the central band is having more tensile strength. Okay, now coming to the membranous portion of the interosseous membrane. The membranous portion is described as soft and thin structure that lies adjacent proximally and distally to the central band. So these fibers, the membranous portion, which is soft and thin structure that lies adjacent proximally and distally to the central band. So if you consider here, so this one is the proximal part. This proximal part of this and the distal part of this interosseous membrane, on the adjacent sides of this, here you can find this membranous part. Okay, membranous portion of the interosseous membrane. Okay, the dorsal oblique cord. So this is the posterior view. Here you can see this one. This is the posterior view. This is the anterior view. The dorsal oblique cord is considered part of an interosseous membrane and should not be confused with the oblique cord, which is located on the ventral side. Okay, so this is the dorsal oblique cord and this should not be confused with the ventral oblique cord here. Okay, and here this oblique cord on the ventral side, which is not considered under the interosseous membrane, but this dorsal oblique cord is considered under the interosseous membrane. That is the difference between the ventral oblique cord and the dorsal oblique cord. Okay, the dorsal oblique cord extends from the proximal quarter of the ulna to the middle region of the radius. So proximal quarter means the proximal at the upper 1/4 part of the ulna to the middle region of the radius. So to the middle region of the radius, this fibers of dorsal oblique cord are present. Okay, these fibers run counter to the central band. So that means the same way this oblique cord which runs 90 degrees with that of the fibers which are running in the interosseous membrane, the same way here this one also, that means on the opposite way these fibers are running to the central band. Okay, now so we have seen this interosseous membrane, and this interosseous membrane is considered to be the one of the stabilizing structure for this radio-ulnar joint, and this consisting of three structures or three components. One is the central band, membranous portion, and the dorsal oblique cord, and how these structures are going to work together to maintain this stability, and based upon these things the interosseous membrane functions can be explained. Okay, so normally, as you people know that by studying in first year, so this interosseous membrane performs some of the functions. You people know that it will binds the radius and ulna to each other, and it also provides attachment to many muscles, and it transmits forces applied to the radius through the hand to the ulna, or a weight of the upper limb can be transmitted to the hand. Okay, and this transmission is necessary as the radius is the main bone which is taking part in the wrist joint, while the ulna is the main bone taking part in the elbow joint. So these are all the things you people have studied earlier. Now in this biomechanics, how this interosseous membrane is going to work? Yes, so it maintains space. Okay, here the interosseous membrane maintains space between the radius and ulna during forearm rotation, whether it may be a pronation or a supination. Okay, and some of the investigations through MRI by Nakamura and associates, the central band remains taut. So the central band, what we have seen earlier, this is the central band. So the central band remains taut throughout the forearm rotation. So it is become taut, that means it becomes stiff during forearm rotation, whether it may be a pronation or supination. Okay, and because of this thing, what will happen? So it is keeping the radius and ulna apart. So because of this structure which is become tight in between them, it creates some space between the radius and ulna. Okay. Now coming to the membranous portion, which is the soft and thin portion of the interosseous membrane, evidenced some wavy deformations at maximum supination and in neutral position. So the fibers will show some wavy deformations at maximum supination and in neutral position. That means if the fibers are showing some wavy deformations, means it is getting some relaxed position, isn't it? Yes. Next. Okay. Afterwards, and the deformations also occurred around the oblique cord. So deformations also occurred around the oblique cord at maximum pronation. So here the oblique cord you have to consider here is the dorsal oblique cord. So the dorsal oblique cord also have some deformation at maximum pronation. Okay. So finally, the interosseous membrane protects the proximal radio-ulnar joint by transferring some of the compressive loads at the distal radius to the proximal ulna. Okay, the interosseous membrane protects the proximal radio-ulnar joint. Proximal radio-ulnar joint by transferring some of the compressive loads at the distal radius to the proximal ulna. So how it takes place means, so once the compressive load is taking place and this one is transferred through the interosseous membrane onto the proximal ulna. So this is the way of conduction of the compressive force from a wrist, from the hand, and then it moves to the radius, and then it reaches to the interosseous membrane at the middle, and then it reaches to the proximal part of the ulna. Okay, and the interosseous membrane maintains transverse stability of the forearm during compressive load transfers from the hand to the elbow. So not only it is sending this compressive forces, but also it maintains transverse stability of the forearm. So in this way, also, when the force is taking over, in the transverse stability of the forearm is also maintained by this interosseous membrane. The maximum strain in the fibers of the central band was found to occur when the forearm was in neutral position. So in the neutral position, maximum strain in the fibers can be seen, that is mid-prone position. Okay, so although the central band is taut during pronation and supination, but during in mid-prone position, the central band undergoes maximum strain. Force in the interosseous membrane that depends on elbow flexion angle and forearm rotation ranges from a minimum of 8 newtons in full elbow extension with neutral forearm rotation to a maximum of 43 newtons at 30 degrees of elbow flexion with the forearm supinated. Okay. The largest of all forces was found in supination in all flexion angles. So the maximum forces are found in supination in all flexion angles. Okay, and the average proportion of total load in each bone in supination was 68% in the distal radius and 32% in the distal ulna, 51% in the proximal radius and 49% in the proximal ulna. These are the average proportion of the total load is transferred in supination. Okay, and the interosseous membrane transfers loads from the wrist to the proximal forearm via fibers that run from the distal radius to the proximal ulna. So the fibers in the central band are relaxed in both full supination and full pronation. But when the movement starts, supination starts and the pronation starts, then the central band becomes taut. And after full supination, it is going to be relaxed. And full pronation also, it is going to be relaxed. And which are the structures are going to be taut then? Then this oblique cord, during pronation, it becomes relaxed. But during supination, that structure will become taut during rotation. Okay. So a reciprocal relationship exists between the radius and ulna in axial force transmission. So in an axial force transmission through the radius was found to be least at the extremities of supination and increased as the forearm moved from supination to pronation. Whereas the axial force transmitted through the ulna was least at the extreme of pronation and gradually increased as the forearm moved to supination. So here you can see, so from hand to upper part of the ulna, it is the maximum amount of forces from distal to proximal, which is carried from radius and then to ulna. This is from distal to proximal. So axial compression from top here, so from upper border, so from ulna it is getting, the forces are getting from the ulna and then it reaches to radius. Okay, this is the way, reciprocal way, and the force through the radius was found to be less during the extremes of supination, and increased as the forearm moved from supination to pronation. Okay, but as the axial force transmitted through the ulna was least at the extreme pronation and gradually increased as the forearm moved into supination. So during pronation and supination, the amount of forces will be least during supination on the radius, and then it is going to be increased from supination to pronation. Whereas the axial force transmitted from the ulna, transmitted through the ulna, was least at the extreme of pronation and gradually increased as the forearm moved from pronation to supination. This point you have to understand well. Okay. And a tract extends from the interosseous membrane and inserts into the distal radio-ulnar joint capsule between the tendon sheaths of the extensor digiti minimi and the extensor carpi ulnaris muscles. So some part of the interosseous membrane which you are going to insert in the distal radio-ulnar joint capsule between the tendon sheets of the extensor digiti minimi and the extensor carpi ulnaris. So this one seen on the dorsal aspect. So in between these two tendons, some of this interosseous membrane is going to be attached. Okay, and that tracts of deep fibers insert directly into the articular disc. So which coming in between these two tendons are going to directly insert with the articular disc. Okay, the tract of the interosseous membrane will become taut in pronation and loose in supination. Okay, and also the articular disc also provides stability for the inferior radio-ulnar joint by binding the distal radius and ulna together. Okay, the radio-ulnar joint capsule, the distal radio-ulnar joint capsule, which is a separate entity from the triangular fibrocartilage, and that means this is articular disc is giving an additional support beyond the radio-ulnar joint capsule. Okay, and this radio-ulnar joint capsule is being a source of limitation of motion when it is invaded any scar tissues after wrist injuries. So this part, the distal radio-ulnar joint capsule, if it is getting fibrosed after any injuries, after any wrist injuries, which is causing the limitation of the distal radio-ulnar joint movements. Okay, these are all about the ligaments and their functions of the radio-ulnar joints. In the next session, we are going to see the function of the radio-ulnar joints. In the functions of the radio-ulnar joints, we are going to see the axis of the motion and the range of motion, and what are the muscles crossing this radio-ulnar joints, and also what are the main muscles which are acting at the radio-ulnar joints. All those things we can see in the next session. Thank you.